Welcome, Dr. Alejandra. It's so good to have you here. And it gives me great pleasure that we are talking about a topic which is so common, so prevalent. We see it, we know it, but we struggle how to kind of manage it, which is polycystic ovarian disease or PCOS. And it's just not about the ovaries itself, as we will delve into. So thank you so much to come on and spend your time educating everyone who wants to be educated.
Yeah, thank you for having me on the show. My name is Dr. Alejandra Bornstein. I'm a board certified endocrinologist and obesity specialist. I basically did all my training in Brooklyn and New York, but have now been living in Philadelphia and working in South Jersey for about the last 9 years. And in the last year, I opened my own practice, which was really about getting to spend more time with patients and slowing down and really take, endocrine, like you said, PCOS is a lot of stuff. That's sort of endocrine in general. There's just so much to cover and so much to do. And, the traditional practice setting with 15 minutes for a follow-up just wasn't working. So that's why I sort of changed the setup, spent a lot more time with people, and that's where I've been in the last year.
So now you have your own practice. I looked up your website, healthyuendo.com, and it's pretty impressive, all the very comprehensive endocrine service that you're able to offer. So tell us, our topic today is PCOS, but we don't have to stick to it. We can kind of color outside the lines, so to speak. Hormones literally impact everything. Sometimes I feel we are just a reflection of what our hormones do inside. It affects our metabolism, our mood, how much you can focus on work, and how much your resilience itself, I feel like sometimes is determined by a hormonal balance. But people don't understand that what they are struggling is because of a hormone issue. I mean, what can you tell them to make them aware maybe something is going wrong or something is off about themselves?
Yeah, I think one thing that's tough is a lot of people come to me with symptoms. At the end of the day, a lot of these conditions, the symptoms can be nonspecific, right? We have a lot of different conditions that could include fatigue, brain fog, tendency towards weight gain, insulin resistance. So there are a lot of different things that can be going on. But, if it's like ongoing symptoms, something just feels off, doesn't feel right, I think it's always worth getting evaluated. You do have women just say they don't feel like themselves or that this has been an ongoing issue. PCOS is interesting because I think it is misunderstood a lot. There is a lot of focus on irregular periods, and I was listening to a really interesting endocrine update, and they were talking about how it could take on average like 3 or 4 years to get the diagnosis, which is like shocking to me because to me, I guess because I do it every day, when I see the women, it seems like very obvious, but you'd be amazed at how many women come, they're almost on their own saying, I think I might have PCOS because I always struggle with my weight and my periods have been off and I have hair issues, but they've sort of been blown off by their doctors or have never really been offered anything beyond just birth control. And, birth control really only covers like a small part of what PCOS is.
Okay, so let's kind of deep dive into PCOS. I said before, PCOS is polycystic ovarian syndrome, but can you talk about, apart from having cysts in the ovary, hence the name polycystic, uh, just the spectrum of the syndrome?
Yeah. So it's funny. I think the name in itself probably needs to change. It's a bit of a misnomer because you don't even need to have cysts in the ovaries to diagnose PCOS. And I would argue that the majority of my women were not even bothering with the ultrasound, right? So, we use nowadays like the Rotterdam criteria, which basically says you need two of the three. So one is like any sign of like high testosterone, which is right, hyperandrogenism and PCOS. So that can be the irregular periods. It can be from the blood work, you know.
Hold on, let's go back to what do you mean by hyperandrogenism? Are they excessive
Yes,
hair on their face,
right.
on their
So,
body?
right, hyperandrogenism, right, is, we don't exactly know why it happens in PCOS. We just know there's this overactivity in the ovaries, basically this overstimulation. Everybody has testosterone and estrogen. The balance is just getting flipped towards extra testosterone. So women can start to have the irregular periods, but it can also be signs like thinning hair. I always ask the question, I've changed it to, is your hair thinning or changing? Because hair loss, realistically, we all have a certain amount of turnover, and I realized I needed to change how I asked that question. But thinning hair on the head, increased facial or body hair, I think is a big struggle for a lot of women. Acne is the other thing to look for. So we're looking at blood work that shows elevated testosterone, or DHEA is the other one we look at. That's basically a weaker testosterone form, androgen, made in the adrenal glands. Irregular periods, and then 3 is polycystic ovaries, right? Multiple little cysts in the ovaries. That interesting, the talk I was listening to also mentioned that the ultrasound needs to be done correctly in the place that does a lot of them to be seen correctly, so that we can get a lot of false negatives as well. And I would argue I do get a lot of times when I get the ultrasound, it doesn't show much, so I think that is true that we don't always see it. But typically the women are coming to me with sort of classic symptoms, either with the irregular periods, some of these other symptoms, classic symptoms of the acne, the hair issue, and then we see that the blood work is positive, and that's like enough to diagnose. Now, those are, I guess, the symptoms people think of, the testosterone symptoms. But the other side is the metabolic side, which is a big one, right? So insulin resistance is really big. It can be anywhere from, like, depending where you read, 50 to 80% of women with PCOS will have insulin resistance. And it's not even necessarily women who are overweight or have obesity. It can be in women with normal BMI as well. That risk is there. There's increased risk for diabetes as well. And there's a tendency for women with PCOS to gain weight. There are all these changes that the testosterone does and things that predispose to like increased visceral fat, like that belly fat, increased weight gain with that insulin resistance. And then it becomes this vicious cycle where as the women gain weight, the PCOS worsens. And they come to me in this like cycle of that.
So in this cycle, the chicken came first or the egg came first?
And that's, I think that's always the question. When you try to look up what is the cause of PCOS, you're going to find like a long list of theories. There do seem to be some genes like involved, and there may be certain genes that are more likely to give the insulin resistance than others. Interestingly, another big thing that's coming up is that women with PCOS have low inositol. So inositol,
Yes, yes, what is that?
yeah, so inositol is kind of categorized as a B vitamin, although it's more of a sugar compound. And it does like a lot of hormone regulation in the body and glucose regulation. And it looks like women with PCOS actually might excrete more inositol in the urine, so they're losing inositol, and that seems to drive some of the insulin resistance and some of the other issues. So inositol could be an issue. It could be genetics. There's a lot of stuff now about the gut microbiome too, that basically women have overgrowth of like the wrong kind of bacteria. That can be true in anyone with weight issues, but particularly PCOS, we're seeing certain overgrowths and again, predisposing to weight gain and insulin resistance. So realistically, it's probably a lot of factors, piling on, and then we don't know what triggered the first one, but then it just keeps going.
So interestingly, I've heard a lot of connection between gut microbiome and metabolic syndrome, but I did not realize there was an association between PCOS and gut microbiome. That's very interesting to me. And even this
Yeah.
inositol connection you're talking about is absolutely interesting. So, I'm going to go a little bit earlier in a woman's life, right? When women get their periods, when they get their periods, the cycles are irregular in the first couple of years or something like that.
Right.
So when should they, if a mom is listening to this, when should the mom be like, oh, I wonder if my child has PCOS versus normal irregular periods at the beginning of your early stage of your menstrual cycles?
I mean, I think it's reasonable to wait a couple of years. I think it's also like looking at the other symptoms. I think the women that started young will give a story of sort of they hit puberty and the periods were off and then they started gaining a lot of weight. So it's often like, I guess looking at what other symptoms are there, right? If she's having some irregular periods, but everything else seems completely normal, maybe I'd be less suspicious than if we're starting to see a lot of other stuff going on. I will say, unfortunately, a lot of teenage girls, I think, end up just getting put on birth control before anyone really checked the numbers. They're just like, okay, let's give you the birth control to help regulate the periods. So I will have older, women tell me, well, my periods are irregular and I was just put on birth control. So it was never like fully investigated at that age.
So it's very interesting. So they have irregular periods, but they have a bigger disease process, a bigger syndrome, which is affecting them head to toe, right? I mean, they
Right.
could have insulin resistance, they could have high triglyceride levels, the waist circumference can be elevated, and they can have higher testosterone levels, loss of hair, mood changes. But only the period part gets treated with birth control.
Yes. Yes. Yeah. So I think, birth control still clearly has benefits. It will bring down the numbers. But sometimes it feels like a bit of a band-aid because as soon as they stop it, everything goes back, and it's not always addressing all the issues going on. Like the periods will regulate. It can help with some of the skin issues. A lot of times what treatment we're using or picking has to do with where their main concerns, because PCOS can, certain symptoms can predominate depending on the person. So depending on what's dominating, we sort of go down different routes. So we look at all that. A lot of my focus now is on helping women with PCOS lose weight and, work on the insulin resistance component, because when we can do that, a lot of the PCOS starts to just improve naturally as opposed to just giving a medicine to lower the hormone levels. We can start to just improve their whole system.
So, if I'm hearing you correct, the treatment for polycystic ovarian syndrome or PCOS is more getting their weight or the primary cause of weight gain better, and that auto corrects the other hormonal issues.
Yeah, for a lot of women, I will say, I've had some women that despite losing a pretty significant weight, the numbers are just there and they need more help with other things. That has become a lot of my focus because I've just seen a lot of women when we correct that issue, a lot of it improves naturally. Interestingly, I have some women that didn't really start showing major PCOS symptoms until there was a time in their life they gained weight and it kind of like revealed itself there. It was maybe they went through big stressors, had a baby, gained weight, and then started having symptoms. So the weight issue is like all very closely tied in.
So,
Um,
how do you help them? I mean, they are insulin resistant, and we know patients with insulin resistance, it's very difficult for them to shed the pounds. So, what interventions do you do which can help them?
So it's really a combination. There's always going to be like a lot of nutrition and exercise counseling. There isn't necessarily, I would say, a special magical PCOS diet, despite what you'll see out there. But a lot of it for me comes down to, it's going to be high protein, high fiber, and ideally, decreasing processed carbs. A big thing for me in diet is that it needs to be sustainable and work on people's lifestyles. So over the years, I've gotten away from like super strict or super restrictive diets and just working on like good quality diet, good balance of nutrients where people feel more full and satisfied and can keep it going longer. Ideally, we incorporate like exercise, strength training, super important as you build muscle mass, increases your basal metabolic rate. So it's just a way to improve your metabolism naturally. And then there's the medication component. So metformin is the traditional one. It's an oldie but a goodie, we sometimes say, that can help with insulin resistance. That being said, even though it's used a lot, I would say most of my patients don't have the best response to metformin. I would say a lot of women that come to me have already tried it and will tell me, no, it didn't really help. So even though I still use it, especially if cost is a factor because it's cheap, it's always worth a try. I would say it's just not always as effective as we'd like it to be. But every once in a while, I have a woman who's really responsive to it, and we don't always. I don't have a good predictor for why. If you could have women with similar characteristics, and then GLP-1 agonists are the big one.
So, before we go to GLP-1, let's talk a little bit more about metformin. So,
Yeah.
yes, oldie but a goodie, as you said. Apart from increasing the insulin sensitivity or making the body more responsive to this hormone insulin, how does it help in PCOS? Does it cause weight loss? what is the mechanism?
Yeah, I always see it as, I think we don't 100% understand, but again, we're talking about this like vicious cycle where, the androgens and maybe the low inositol, everything is triggering this insulin resistance and increased visceral fat and all of that. And I think sometimes putting the metformin on can just kind of put a cut on that, and slow that down. And you can potentially see, yes, like the numbers actually come down. So it is going to do more than just the insulin resistance. Like some women I remember one very dramatic one that had like a period in 2 years and decided to try metformin, and all of a sudden she got her period. So sometimes it really can regulate for certain women. It can be enough to really regulate and normalize hormones and even get the periods back on track.
So
Um,
the question, you kind of led me to it.
sorry.
What would be a response of treatment for PCOS?
Yeah, so I give them anytime we're starting something, you probably want to give it at least 2 or 3 months. It's not going to be an instant response. But yeah, we're looking at what's going on with the periods. Are they able to lose weight? Skin improvement. I will say hair is always the most stubborn symptom, either whether it's the thinning hair on the head or facial hair. That's going to be one of the toughest symptoms in PCOS. Actually, for that specifically, spironolactone is probably better. So spironolactone is a diuretic, a water pill. You would know, be familiar with it. But it blocks testosterone and seems to be particularly good for those issues. So some women, even when everything else is improving, we do add on spironolactone to help with those. So probably period and the weight are the two biggest ones I'm looking for to see if we're getting the proper response.
So, I'm sure like now with the advent of GLP-1s, you have a way more tools in your toolkit to treat. But before that, it was just, metformin, spironolactone, and would you do any other hormone supplementation?
Yeah, we definitely use birth control. For one reason or another, I feel like a lot of the women that come to me have just don't want to do it. Maybe they had a lot of side effects in the past. So, you know, for what, some of them are on and that's fine. We continue it and just work. Some of them we started, but I do have a lot of women that maybe didn't tolerate it for one reason and just tell me they'd rather not go that route unless we have to. So oddly, even though it's technically like the gold standard, I find myself not always using as much as I used to. But yeah, we were more limited in choices. So the GLP-1s have become really big. So the thing with the GLP-1 agonists, it's not officially FDA approved for PCOS, although I think it will be. I honestly think the only reason it's not is because there unfortunately is just less of a focus on women's health. So they seem to be pushing for almost every other indication. I had one of the reps in the office and I asked that question. I was like, when are we getting FDA approval for PCOS? And she's like, every office I go to, they keep asking me that. I'm like, yeah, because it's an amazing drug for this. Unfortunately, it's just not their focus, but I've seen amazing results. And the study, there are little studies out there really showing it. Women with PCOS just really respond to the GLP-1 agonists. They lose weight, their hormones really regulate. So sometimes I start with that because sometimes that's really enough to just reverse everything and you can keep it really simple and not do, just do this one medication that can sort of take care of everything.
I still don't understand. I mean, I understand GLP-1s are ridiculously expensive, and we are still trying to find a way to make it cost efficient for diabetic patients and patients who have other severe morbid obese conditions, etc. But this PCOS is pretty much another part of the whole metabolic syndrome, resistance conundrum. But I'm surprised the GLP-1s haven't caught up to it as yet.
Yeah, as I said, I think it's just, at the end of the day, to get the indication, the pharmaceutical company has to push for it, and they seem to be focused, they just, Zepbound just got the sleep apnea approval. I think
Which is all
fatty livers,
part of the
which
metabolic.
is great too. Talking to one of the reps, it sounds like fatty liver there is on the horizon as probably the next thing that will get approved.
Yeah.
So I don't know why there hasn't been this focus on PCOS. I mean, it just affects so many women, could be like maybe like 10% of women out there, or more depending what study you read. So it's a big thing. Luckily, sometimes we find ways, since a lot of the women do have issues with their weight, sometimes we can get it approved that way, for weight loss. Since these women have insulin resistance, and there can be issues with the blood sugars, you can also get an oral glucose tolerance test, which is sort of the old-fashioned way to diagnose diabetes, but can also detect the very earliest stages and detect inappropriate responses to blood sugar, which is kind of what these women have. So I have also sometimes been able to detect very early stage diabetes, and sometimes you can get it approved that way. So we're always sort of looking for how can we get it approved for somebody. And so I've been lucky that we've been able to get it for a lot of patients in some way.
What is the association between PCOS and infertility, which is, most of the time patients are spending out of their pocket for infertility treatments in the US. So what is the connection between PCOS and infertility?
So it's the high androgens, basically anovulation, right? They're just not ovulating.
Hmm.
So interestingly, that's where I think, doing something the GLP-1, having them lose weight is one of the best things you can do in preparation for fertility is, to get the hormones reversed. And, so doing that, metformin can help. Giving them something they use letrozole or things like that to induce ovulation is used a lot in PCOS. Interestingly, I always remind women because everyone gets nervous about the fertility issue is sometimes it's hard, sometimes it's not as hard as women think. So, I prepare women, it may be worse than you think, but it's not necessarily I don't know, death sentence that you'll never be able to conceive. A lot of women, especially I think now as we're getting with better treatments, we can restore a lot of normal numbers. Myo-inositol, right, inositol supplement, seems like it's pretty good for restoring ovulation.
Oh, wow. Okay.
So
Hmm.
it's such an interesting thing. For me personally with inositol, I started using it a little in women that were kind of nervous about taking a prescription medication. And, there's always been on and off studies about using it. So I was like, okay, it's totally harmless. Let's try it. And I was surprised. And I did have actually a patient who had been thinking about wanting to conceive. And I think after a couple of months, she messaged me that she was pregnant. I was like, okay, this is pretty effective. And then I think new guidelines for PCOS came out about 2 years ago, and they actually added myo-inositol onto the guidelines to sort of consider it, which I thought was really impressive because,
Yes.
supplements don't make it to guidelines very often. And the more you read about it, I was reading a lot. Inositol, it can do a lot. As I said, for women trying to conceive, it can help restore regular ovulation. It can help with the insulin resistance. It looks like it does normalize a lot of the hormone levels. So it's pretty impressive as a supplement.
I'm not pro supplement. I'm not going to call myself anti supplement. I'm not pro supplement because I truly believe let's try our best to just have a very balanced meal and get everything we
Mhm.
need out of it. But I completely understand, our food is nutrition deficient and therefore we may have to supplement a little bit here and there. Are there any specific supplements apart? You've mentioned inositol. Any other supplements in women who have PCOS, insulin resistance, you've seen work in your practice, in your scope of practice?
Yeah. So the other one I'm going with, we, touched on is the gut microbiome. So there are studies coming out, right, about women with PCOS either taking probiotics or the symbiotics, right, pre and pro together, that it can help with weight loss. And I guess as we restore the good bacteria, it can help to regulate some of the hormone levels too. So that's probably the other one, I have women consider taking. Plus, if they're on a GLP-1 agonist, it kind of helps combat some of the constipation that comes. It seems to really help regulate from that side. So there's multiple benefits. But those are probably the two, I think, when women ask me about supplements for PCOS. And with the myo-inositol, the only warning I give women is I think there are a lot of companies sort of taking advantage and saying this is a PCOS supplement and putting a really big price tag on
Of
it.
course,
And, a
of
patient asked
course.
me about one of these ones and I looked it up and I was like, this is just myo-inositol. It's literally just myo-inositol with a fancy packaging, and I was like, don't get that. I was like, get the generic. The only thing with supplements is because they're not well regulated. I'm like, just look for ones that are regulated, right? Or allow outside testing. So it's looking for, it'll either say USP or GMP means they allow outside testers. So I think that's the most important thing when picking a supplement. You'll just
So,
know there's better quality control.
So tell me about the two USG. What was those two
USP, yeah. So
USP?
USP or GMP are the two it'll say. You'll see like a little like writing on it somewhere on the bottle. So sometimes even for me, if you know, on Amazon where you can sort of look through the pictures and it should be somewhere on the label. And I know like Nature Made is a brand that definitely is certified. So like, you know, if they have it, but I don't know if they specifically do minoxidil. But yeah, you can, that's the best way to kind of have a sense of that this is better quality supplement. And then the other side of supplements is more nutritional related, right? So if we're working on weight loss, because the protein is really important, some women are struggling to hit protein targets. I actually tell people ideally, you know, you want to get at least to 100 grams of protein a day. If you're going over, that's bonus. But if we're on a medicine that reduces appetite, it can be a real battle. So a lot of my patients are drinking like protein shakes or things like that. And then fiber is the other one, which is also a natural prebiotic. So if they're not able, because with fiber, I also recommend like 25 grams of fiber, which again is a lot. So if they're not able to get that from diet, I think a fiber supplement is reasonable.
So that's very interesting. I completely enjoyed that whole package. Now, let's talk about something which honestly I haven't spoken a whole lot in my podcast episodes is what are your recommendations to manage the side effects of GLP-1s? The nausea, the vomiting, the constipation,
Mhm.
maybe even dehydration. Do you have any tips or tricks to overcome that?
Yeah. I think there are definitely ways to do it. I think sometimes the symptoms are not as bad as people think. I will say, right, you have two big ones right now. You have semaglutide, which is Ozempic and Wegovy, and tirzepatide, which is Mounjaro and
Yeah.
Zepbound. And Mounjaro and Zepbound, I will say, has significantly less side effects than the Ozempic or Wegovy. So one is pick the right one if you can, because it will make a big difference. In terms of the nausea and heartburn, a lot of it is what I tell people is the first couple shots are probably going to be the worst ones if you are going to have symptoms. So one is just, you know, maybe take it on the weekend when you're not going to be busy. And as long as it's tolerable, really just try to power through it because I have so many patients that will tell me they were nauseous at first and then it got better. So part of it is just don't quit too early because sometimes it's that first shot and even by the second one, they're like, oh, the second one was already much better. Um, you know, the way you eat matters. So rich, greasy, fatty foods are going to trigger more symptoms, or sometimes people are just not used to them and just go out and eat a larger meal that's just going to sit really heavy. So part of it is the way you eat. I always tell people if there's a random day you had stomach upset, look at what you ate that day. I've had a lot of people able to pinpoint what food did it for them. And I always tell people pizza is a big culprit. For whatever reason, pizza just is one that'll set things off.
True.
Um, Sometimes I will give nausea medicine. My policy with that is like, I think if you just need a pill every once in a while you're building up the dose, I don't think it's a big deal. I have a lot of people I've given nausea medicine to and come back and say only took it like 4 or 5 times and then they felt better. So to me, you know, it's fine. We start the dose low, we build up gradually. The longer you're on a dose, the less side effects you're going to have. Typically, when you bump up the dose, there may be a little flare up of side effects and then it settles back down, but usually not as bad as the initial. And then once people find whatever is that right steady state dose, I have a lot of people tell me side effects pretty much completely went away. Yeah, constipation was the other one. So constipation, water is super important. The meds reduce thirst along with hunger, so sometimes people are just literally forgetting to drink water. So water and fiber, those are probably the two major things that will keep the bowel movements regular, the probiotic, and if it's really slow, you know, something like Miralax. But I think if you stay on top of your water, your fiber, your probiotic, it's a little slower, but usually nothing major.
The point I was trying to make earlier is we're talking about greasy foods, and the biggest problem is high fat content greasy food. Those themselves reduce the rate at which the stomach is emptying. And when you're already on a GLP-1, which is also reducing your rate
Yeah.
of stomach emptying, the food just sits there. And, I've heard a lot of people talk about uh, uh, disgusting burps and tasting their burps and
Yeah.
refluxing, and even patients going to ENT folks because so much of acid reflux,
Yeah.
etc. How about so for those patients who forget that they can survive with less food and eat excessively and have severe indigestion. What is your thought on, remedies such as so-called digestive enzymes, etc.? Have you noticed, have you used them at all?
That I have not used yet, no. The only other thing I give is more like antacids, right? Like famotidine, things like that. I have not done the
Oh,
enzymes.
okay.
Um, Sometimes it's about cutting back the dose, and letting somebody stay on a low dose a little longer. I will say with tirzepatide, it's great. Like I really have very few people that have persistent symptoms where they just cannot be on it. Unfortunately, it's much worse with semaglutide.
Let's talk about the other big side effect of the GLP-1s because you actually touched on it, the protein intake. They are
Hmm.
losing, not eating much, they are not drinking much. Maybe they are tired more and may not focus on exercise as well or strength training, and they end up losing a lot of protein. How do you push, or what is your, what is the carrot you hang in front of your patients to make sure they consume your protein and hit the gym?
Yeah. I think it helps to have a really good discussion before you start. I think a lot of people sort of see this medicine as we just sort of prescribe it and hand it out and that's it. And, it just doesn't work that way. At the end of the day, they're not magic. The counseling makes a huge difference, doing everything together. So already putting that in their head from the beginning really makes a difference. I have a body composition scale in my office, so we are tracking muscle mass. And for patients who are not getting in their workouts, sometimes it's a real eye opener for them, where they're like see a lot of muscle loss and that's what they need. And then for the ones that are working out, it's super motivating because it's also really exciting when they're like, wow, I lost all fat. And sometimes some of my patients that are losing weight a little slower, but then they get on the scale, and from a body composition standpoint, they're actually doing really well. Like, sometimes they've even gained muscle right in the month. It's like their numbers look great. So I think the body composition scale helps. I think things like protein shakes help. Like you mentioned, in the ideal world, everything would just come from natural diet, but it's just
Yes.
not always realistic, especially for people who are like super busy on the go. And I would say ultimately, like it has to work in the life or it's not going to happen. And something like Premier Protein, I love because it's like these little bottles and they have 30 grams of protein. So you're getting 30 grams right there. And I tell people just have like protein on your brain, even if it's
Yeah.
not an exact number. Just always be thinking about how can I eat protein, and sometimes that's good enough, right? Like just always have it on your mind. What can I do? Make sure every meal has a protein. Even if it's like a handful of nuts, just something. And then the exercise side, it's really about taking the pressure off. I think with exercise, it's really easy to get caught in this like all or nothing mentality. I have to remind myself all the time not to get there, and just changing away from not every workout has to be your best workout. It's more important to get it done, right? Especially in the beginning, it can be really intimidating, I think, for people if they haven't worked out, if they're really tired, they're really busy, just working out seems I'm amazed how people can fix so many other things in their life, but the workout is the one they struggle with. So I usually tell people aim for doing something 2 or 3 times a week. It can be 5 or 10 minutes to start. Like I love home workouts. It can be body weight. It can be resistance bands. Like don't worry about the intensity. I'll completely take the pressure off and just focus on consistency. If you're doing something 3 days a week, you're going to get stronger and then you can start pushing yourself. But just like take the pressure off. Don't worry about it at all in the beginning. And it can make a huge difference. I noticed that even for myself, that I used to think I had to go to the gym and do 30 minutes on the treadmill, then do the lifting. And I have little kids, and the end result, I was never going. The idea of going to the gym when I came home tired, it just was not happening. And then I think it started with the pandemic. I started doing like workout videos at home in our basement. And I started doing things that I wouldn't have thought of doing before with the videos and some dance cardio and just random things that maybe wouldn't have felt like proper workout before or not strong enough. And the end result was I was working out a lot more and I got in much better shape. So I think
Yes.
we have to like reframe the way we think about it, and that can make the difference.
Absolutely. Sometimes, like, when I'm busy and I haven't worked out, I literally tell my daughter, can you just go for a walk? In that way, I'm hitting two birds with one stone.
Hmm.
I'm spending time with her, and we are also walking. So it kind of,
Yeah.
just have to find your way. I always say, take the stairs, park your car really far away. So that gives you a little extra steps here and there. So non-exercise workouts or
Hmm.
non-exercise thermogenesis, it all adds in as well.
Yeah.
So I think,
Yeah, the other one says you mentioned that. The other one I have people do, I have a little workout I give them that are body weight exercises to do throughout the day. So like literally you're sitting at the desk, get up and do 10 squats. And
yes.
I had a trainer I was chatting with when I was setting up my practice, and I was asking her, because it's like a lot of my patients have bad knees, like what do you recommend? And she says what she tells patients, if you can sit down and get out of a chair, that's a squat. You don't have to make, so like if it has to be, it can be chair squats. But you can do these just little spurts throughout the day and it could really add up. So I have all these exercises that they can just incorporate, take 1 minute break in between whatever they're doing and just add it in that way.
It's so funny. I had a guest, Miss Alicia O'Connor. She is our director of our student center here in Medical University of South Carolina, and she gave like a 5 minute workout, which you can do at your desk, and you can do it several times a day. And she was like, just do 10 desk push-ups, and then sit up
Mm-hmm.
and get off your thing. Just walk in place, march in place. There are honestly a lot of things you can do if you decide I am going to incorporate it throughout my day. Now, I kind of feel like now the GLP-1 have been here long enough that you may be seeing patients who want to get off of it. So, do you have a protocol how you wean the patients off so that they don't gain back all the weight?
Yeah. So, I mean, one thing I tell my patients is just to consider staying on them. Obesity is classified as like a chronic disease by most medical associations. We just know there's a genetic predisposition, there's the hormones, right? Whether it's PCOS in older women, menopause, medical conditions, medications around. There's just so many things that factor into weight gain. The best example I've always heard is like when you take medicine for blood pressure, you don't stop it when your blood pressure improves. And that I strongly encourage women to, or, any of my patients to just consider staying on it. If there's this thing out there that's going to make you healthy and feel good, like, why not? I think there's a lot of bias around it. For some women, some shame, like they don't want their family to know they're on it. But realistically, I'm like, if something's out there helping you feel really good, I would consider staying on it. If somebody's like really eager to come off, I would say we want to see at least a year or two of really solid weight maintenance too. Because if you just, what's not going to work is like, can I just do this to jumpstart my diet? Or for 3 months, I want to lose weight before whatever wedding or whatever it is. That's just the equivalent of a crash diet. It's not going to work. So if every once I've had somebody for one reason or another, and what we do is they've been on it for a long time, they've been maintaining, bring the dose down gradually and see how they do. I have
So,
a small handful that were okay. A lot of them do end up just choosing to stay on it. And we do whatever's the lowest dose that'll hold people steady, so it definitely doesn't have to be the full dose, right, to maintain.
I mean, it's so funny how there are more women who are successfully dieting and exercising, but actually they're on GLP-1, and somehow they are, don't want to be honest about it and say, hey, I'm taking a GLP-1 and I'm also dieting and exercising, or I'm eating better and exercising.
Yeah.
There's still a lot of stigma, unfortunately, around it. A common term which is being thrown around is microdosing of the GLP-1, which I assume they're just taking the lowest dose needed to
Yeah.
maintain the weight. But am I correct about that?
Yeah, I think that's the idea. I mean, one question is, because people are talking about could you microdose for the cardiac benefits, or that's why they say they're taking it. But I think that really needs to be studied because the studies showing cardiac benefit were at higher doses. So, I was just thinking about that the other day. I was talking to my husband, I was like, but we don't really know if taking like a baby dose is it enough to give you like the reduced risk of heart attack and stroke. That really needs to be studied. Um, I am probably a little more flexible in terms of who I would give it to. There are clear-cut guidelines with the obesity guidelines, like BMI over 30, BMI over 27, with some complication related to weight, right? High blood pressure, high cholesterol. And typically I'm sticking with that, but there are certain scenarios. Sometimes I had somebody that gained a lot of weight for something is not quite there, but getting very close, or they're having insulin resistance, increased visceral fat. And sometimes I feel like those are the guidelines, but also if this is somebody who's gaining weight, not feeling well, do I really need to wait till this person puts on another 10 pounds before starting? From an insurance standpoint, yes, but so there are sometimes where I'll bend those rules if they're okay with, paying a cash situation. The microdosing, we'll see. I mean, I joke sometimes I think in the future everyone's going to be on it because we're seeing so many all around benefits.
Absolutely.
But yeah, it needs to be studied. Like, what are the benefits when you're on like these tiny doses? Is that enough to see all these benefits we're talking about would be the question, right?
Yeah, absolutely. No, I think the whole cardiac benefits comes from the disappearance of high blood pressure and the improvement of your lipid profile, etc., which comes with, eating better and exercising and your appetite control. I think that's where all of it comes from. And there are studies looking at a more hormonal cellular level benefit from the GLP-1, but we have to wait and see.
Yeah. I mean, the thing with GLP-1s, I like when I've given talks, I always put up this like graphic that shows all the effects of them, what we call the incretin effect, because it does affect so many different, organs in the body. So really, we think of it as it does this and this primarily, but really it does go into bone. It does go into the liver, it goes into all these places. So yeah, I think a lot of that still remains to be seen. Like, is it all just weight loss, which a lot of it could be, the insulin regulation, so I think we still need more to understand where all these benefits are coming from. Primarily probably is weight related, but it could go really beyond that.
Absolutely. So, we are kind of coming to the end of our podcast here. So, is there a story, either your personal story or your patient's personal story, where they rebooted their health and it kind of touched you in some way? Will you be willing to share?
Yeah, I think one thing I hear from a lot of patients and where I'd love to do this is, yeah, patients just come in, there's a lot of, they come, I feel like it's not even one patient. I've had so many with the same story, but that they come that they've kind of been blown off, right? Like nobody's taken them seriously. They have all these symptoms. Weight loss, the one that hit me was a woman did start crying in my office and said I was the first person that ever told her it wasn't her fault. And that really hit me, that every doctor was just like, and even her family, like everybody criticized her, just eat less, just eat less. Mm-hmm. And it just, it's so much more than that. And it actually like broke my heart when she said that. And to take patients like that and help them lose weight and they come back. And I would say, I think people also make these drugs very superficial, like it's just about getting skinny. And I can tell you that is not what anyone talks about. The number one thing any of my patients say when they come in is, I feel so good. And number two is usually something related to mobility. I had another patient that talked about she was in her 60s playing with her grandkids on the floor, not really paying attention. And, her son was like, just sitting on the floor with them. Like she never would have done that before. Or, they were outside and she was in a reclining chair and she just got up. And didn't even think about it until she was standing up and walking around, that in the past, that would have been a big struggle where she was getting up and she didn't even think about it. She just stood up and walked. So yes, I'm sure a lot of people are happy with the way they look, but for most of my patients, it's just really not about that. It's about how they feel. And I think for them having a doctor that's like understanding and rooting for them and like, yeah, not blaming them for it just makes a huge difference.
Absolutely. Well, Alejandra, thank you so much. We started off with such a common disease, PCOS, deep dove into insulin resistance, then metformin for insulin resistance, OCPs, GLP-1s. I mean, the entire spectrum I think we have covered here. And I truly appreciate you taking the time and talking to me and my audience.
All right. Thanks so much for having me. This was great.
Yes. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.